So first off, thanks everybody for joining today. We have another of our virtual seminar series for the computational medicine. I wanted to head off and say, we've had a really great audience so far, and thank you guys so much for joining. A lot of this work came out of, the idea for these seminars came out of the workshop series we had last summer, trying to bring together people from, all the different schools, like School of Medicine, School of Nursing, Trinity, and Pratt. And this is one of our first talks coming from the School of Medicine. So I'm really excited to have Dr. Acker here today to kind of represent what's going on in the space really across the school and kind of covering different areas and giving you all a different perspective of what's happening. And with that, when we had the workshops last summer, one of the things that came out was trying to get a better sense of what's going on around Duke in all of these different areas focused in computational medicine. So we're trying to create this, getting a lot of content around what is the different work that's going on at Duke in this space. So kind of just a reminder that the focus of these seminar series is to have both internal and external people be able to watch the talks, hear more about what's going on at Duke, what's happening in the research. So it is intentionally this virtual seminar setup, so that when we're having the online audience, they are really the intended, attended viewers. And it's not just, a video. Sorry, I keep adding people as we go, but it's not just a video that's being watched, as someone's giving a talk and you're kind of, just kind of seeing what happens being taught in from the back of the room. But it's really being able to be immersed in the presentation, have a strong presentation focused on the virtual audience. So we're really grateful. It looks like already there are tons of people that are from Duke, and I see people from outside of Duke joining already, which is great to see. So thank you all for joining us. This will be posted on YouTube and on the YouTube Pratt channel in the future, and we'll follow up there. And also just mentioning for people who are at Duke in person, we will have a Meet the Speaker event, so you can actually talk to her afterwards in person. We will be in Wilkinson in the lobby. There'll be a coffee hour for networking, so please come if you're if you are at Duke, please come to just meet other people working in the space, interact with other researchers in the space, or if you have more pressing questions following the talk and you want to get into more detail, please come to meet the speaker there as well. With that, I'm going to introduce Dr. Acker and throw it over to her. As I mentioned, we're really excited to have someone coming from I guess we had Dan Buckland last time coming from the emergency medicine side, and now we have Dr. Leah Acker, who's coming from anesthesiology to talk to you about her research. And I'll just do a quick intro and throw it over to you and let you give the talk, and I'll turn off my video so it's not distracting and let you go ahead. Thanks again for being here.
Hello, everyone. I am really thrilled to be joining you today and to tell you a little bit about some of my research, and also to kind of present things from the background of both a practicing neurosurgical anesthesiologist, which is part of my job, and also as a PhD trained engineer who leads a lab trying to look at how we can use bioelectronic signals to predict vulnerability in older surgical patients. So today, I will be telling you a bit about our focused disease state, which is postoperative delirium. And I hope even those of you who aren't clinicians will bear with me a little bit as I sort of go through the definition of what delirium is and tell a little bit of the story of how we've gotten to the point where bioelectronic signals, particularly electroencephalography or EEG, can really make a difference in terms of predicting who is at risk for this disorder, and ultimately even guide basic science research into sort of sources or vulnerabilities within the brain itself and its processes. Then, after we sort of have this case study of how computational and bioelectronic medicine can advance both clinical care and the basic science that eventually gives rise to our understanding of pathology, I'll tell you about our two clinical perioperative research studies. The first one I will tell you about is called POTENT. POTENT stands for preoperative transcutaneous auricular vagus nerve stimulation effects on neurocognitive and neuroinflammatory trends. Basically, this is a bioelectronic neuroimmune modulation study in older adults who are anxious about surgery. We are stimulating the auricular branch of their vagus nerve and seeing if that is able to improve perioperative outcomes. Secondly, we're looking at heart rate variability, which is a measure of vagal tone in post-operative delirium and post-operative inflammatory endpoints. This is a wearable longitudinal heart rate variability measurement study in older surgery patients spanning from about 2 weeks before surgery until a few days afterward. So let's begin by talking about delirium. Delirium is an acute and fluctuating change in attention and arousal. It has kind of 4 features. The first mandatory feature is this fluctuation. Sometimes this manifests as something you might have heard of as sundowning, when someone is totally with it in the morning, but by the time evening comes, they're confused, they can't recognize family members, they don't realize where they are. A second feature is inattention. This can manifest in 2 ways. It can be that you're having a conversation with an individual and they're just out in space looking out the window. It could also be sort of a hyper focus, maybe with something like a ring or a pen, some type of inappropriate focus that manifests as inattention. There are 2 other features, one of which has to be present. One is disorganized thinking, which is an inability to sort of logically connect thoughts. The second optional feature is an altered level of consciousness. So this is either the person who you're like shaking them just to wake them up. They don't just wake up to voice, or it's the person who's kind of like jumping out of their skin. Delirium, even though its presentation can be kind of interesting, is really a serious and common problem. 3 out of every 10 surgery patients who are admitted after their surgeries, aged 55 and older, suffer from post-operative delirium. This is the focus of our research program. Post-operative delirium is very disturbing for patients and their families because it's such an acute change at a time that's already really stressful. It's also very costly. The increased length of hospital stay alone due to post-operative delirium is over $30 billion a year, only in the US, not counting international costs. Finally, those who experience post-operative delirium now have a much greater risk of many poor outcomes. They have a 3-fold risk of being discharged to a skilled nursing facility instead of back home. They have an increased dementia risk 12-fold of a person who did not experience delirium. Their risk of death in the 2 years after that delirium episode increases 4-fold. So this is clearly a very common problem, a very serious problem, and it's a problem where there have been many hypothesized mechanisms. And I want to tell you the story, sort of where we've gone through this, because I think it could be informative for other disorders. And as we think about how bioelectronic and computational medicine might be able to advance care in other spheres. An early kind of hypothesized theory of a source of postoperative delirium is simply that people had too much anesthesia. The predominant kind of mechanistic theory right now is that it is an effect of inflammation and neuroinflammation. And then through our work and the work of others using electrical signals from the brain, we also posit that there is a degree of pre-existing neurocognitive vulnerability that also contributes. So let's start at the beginning with the excessive anesthesia story. The premise of this is essentially that you lose consciousness when you go under for a procedure and it just never quite comes back. So to test this theory, the REGAIN study, which was headed out at the University of Pennsylvania, a multi-center randomized control study of 1,600 participants aged 50 and older who were randomized to either have a spinal anesthetic, which is a shot of a numbing medication in their back, or a general anesthetic where they went all the way to sleep before a hip surgery. This looked at death as its primary outcome, but delirium as a secondary outcome. And it found that there was no difference in the rate of new onset postoperative delirium between those who got the numbing shot, the spinal anesthetic, and those who went all the way under with the general anesthetic. However, there were some challenges in the study, and people weren't inclined to believe this result because we often think, that if you don't have an anesthetic, we don't sort of scramble the brain with a general anesthetic, that you should be at on safer ground in terms of delirium. And yet, in this study, those results differed because 15% of the patients who got a spinal anesthetic randomization actually got a general anesthetic, possibly because it can be very painful to get into the position for that numbing shot when you have a fractured hip. There was also some crossover in the other group. And the most significant sort of challenge was that in our sort of more patient-centered US healthcare system, there are very few people who were willing to be wide awake while surgeons are sort of hammering and sawing, trying to repair a major orthopedic injury like a hip fracture, even if they can't feel a thing because they have a spinal anesthetic. Therefore, this study was repeated in a different population. The Raga study in China was a randomized control study across 9 teaching universities in which patients were either assigned to a regional anesthetic. So again, this is this numbing shot, and it's either spinal or epidural. And patients in this study who had a regional anesthetic, the equivalent of a spinal in the other study, got absolutely no sedation. They were wide awake. Patients in the other arm of the study were randomized to a general anesthetic, so they were completely asleep. And the primary outcome was the incidence of delirium. This study, too, reported that there was not a significant difference in the incidence of delirium between those who got essentially nothing other than a shot in the back, so no sedation, and those who had a full general anesthetic. Therefore, excessive anesthesia is likely not the mechanism of delirium, which pointed to inflammation as a possible cause. It's well known that aseptic surgery, and so by aseptic, I mean totally clean, totally well prepped, very sterile surgery can trigger an acute inflammatory response. Further, we know that individuals who undergo surgery and do develop postoperative delirium have higher circulating levels of inflammatory cytokines in their blood than those who do not develop delirium. Further, we know that this postoperative systemic inflammation degrades the blood-brain barrier. The blood-brain barrier is what separates the systemic circulation, i.e., the blood supply going to the area where the surgery happened, from the brain itself. However, when the blood-brain barrier, which is usually very tight, breaks down, circulating inflammatory cytokines can cross over from the systemic circulation into the brain, leading to neuroinflammation. Together with Nicolo Taranto and Jenny David, we looked at blood-brain barrier expression in animals, these are mice, who did not undergo surgery, and those who did 24 hours after surgery. And you see the proteins associated with the blood-brain barrier shown here in purple and in the lower panels in green were diminished after surgery in the animal model. Further, if we look at the change in the CSF, so the cerebral spinal fluid, versus plasma levels of albumin, so the ratio of albumin in the blood versus in the cerebral spinal fluid in the brain, of this big protein that shouldn't cross the blood-brain barrier unless there's a problem, we see that those who have delirium have a greater CSF to plasma albumin ratio, and that there is a correlation between delirium severity, shown here on the x-axis, and that change in the CSF to plasma albumin ratio. So thus, yes, inflammation and neuroinflammation do seem to be associated with postoperative delirium. However, we should be able to predict some type of vulnerability in advance, because that's what would allow us to determine who should get preventative resources. And that has been a recent focus of my research. So we know from imaging alone, as well as epidemiological data, that the greatest pre-existing risk factor for cognitive or for delirium is pre-existing cognitive impairment, and that neurovascular changes like what you see here are associated with an increased risk of delirium. It's not merely these big plaques like we see on the far right side, but it can also be these smaller indications of neurovascular involvement. This is an area potentially where computational medicine could begin to intervene. However, in this current work that I'll tell you about, we didn't even use imaging. We used EEG. So EEG, or electroencephalography, is a way that you can measure the electrical signals produced on the surface of the brain. We first, working with Dr. Heather Whitson, Dr. Marty Waltendorf, Kathleen Kahlon-Emmerich, and Dr. Miles Berger, decided that we would look at complexity. Complexity is a concept that was developed by another one of our collaborators, whose picture is not shown here, Dr. Lou Lipsitz up at Harvard Medical School. In this definition, complexity is an irregularity in physiological signals, which we believe is due to multiple interacting control processes that all act at different time points. We hypothesized that those who had, sorry, the computer's acting a little bit here, that EEG complexity would be greater before surgery than under a general anesthetic. This just makes sense. If we administer a general anesthetic and we shut down most of the brain, there just aren't as many control processes going on, and this should impact complexity. Further, we hypothesized that individuals who before surgery had greater EEG complexity would have some resilience to delirium because they would have more brain control processes to help get things back on track after the stress of surgery. Yet, what we found was that in the pre-op eyes open state, eyes closed state versus the intra-op eyes closed state, there was actually lower complexity measured as the area under the multi-scale entropy curve shown here in blue than there was during surgery, shown here in orange. To get into this further, we decided that we should look at the different scales of those entropy values. So on the x-axis, you can see the multi-scale entropy values ranging from 1 to 25. On the y-axis, you can see the average frontal EEG complexity for all of the subjects in the study. In blue, you have the pre-operative complexity at each of these scale values with standard error bars. In orange, you have the intra-op. And we found that for nearly every subject, there was a crossover. So at the lower, shorter scale values, indeed, there was greater preoperative versus intraoperative complexity. However, at the longer scale values, there was greater intra-op complexity. We then looked at the 42 out of 50 subjects who demonstrated a single crossover point. Several patients had multiple crossover points, and so they were excluded. And we found that the crossover point was associated with delirium severity. So this begged a question of whether we could leverage natural transitions in brain states, not something as severe as being wide awake versus totally anesthetized, but simpler, more everyday things, to predict a resilient brain versus a less resilient brain, and to better understand underlying neural mechanisms. So it's been known for nearly 100 years that EEG alpha power, so this is the power at roughly 10 hertz, is quite high in the eyes closed state and quite low in the eyes open state. So we asked the question, does the pre-op EEG alpha powers attenuation, so how much alpha drops from the eyes closed state to the eyes open state, have anything to do with the risk of a particular feature of delirium, inattention? The reason that we focused on inattention was because we knew from the literature in everything from ADHD to the executive function deficits in Alzheimer's disease, alpha power and its reactivity, or that decrease from eyes closed to eyes open, was associated with these outcomes. So in this study, patients underwent pre-op 3D CAM testing. So the 3D CAM is a way that you can evaluate for attention and for delirium. Then before surgery, as they were waiting for their procedures, they underwent a pre-op whole head EEG. They closed their eyes for 3 minutes and then they opened it. And we compared alpha power in those two states. Next, they underwent surgery, but not neurological or cardiac surgery, because those impact the brain itself and the circulation respectively. And then finally, each patient underwent repeat delirium and inattention screening twice a day, once in the morning and once in the afternoon, every day until hospital discharge. We found that older adults who were inattentive post-operatively had less alpha attenuation when they went from the eyes closed to eyes open state pre-op. So here you can see the attentive patients and the decrease in alpha power. And in the lower panel here, you can see the inattentive subjects. Pre-op alpha attenuation by inattention status is shown here. So on the x-axis, we have the frequency. On the y-axis, we have the eyes closed minus eyes open power across this frequency spectrum. The attentive patients are shown in black with standard error shown in gray. The green inattentive patients are shown in green. And we see that there's a substantial difference in the amount of alpha attenuation. We broke this up into inattention subgroups, specifically patients who became inattentive after surgery for the first time versus those who were inattentive the whole time, both before and after surgery. And we saw that there was a significant and stepwise difference. We tested this further and showed that for the full alpha range, attentive patients had the most alpha attenuation with eyes opening, followed by the newly inattentive subjects, finally followed by the chronically inattentive subjects. Then we decided to split this into lower and higher alpha because patients who have less attenuation in the lower half of the alpha band, so 7 to 10 hertz, likely would have issues with kind of global arousal and attention, whereas higher alpha, so 10 to 13 hertz, would be more associated with specific attention, so attention to specific visual or auditory stimuli. And we found that this stepwise trend held for the lower half of the alpha band, but not for the upper half of the alpha band. Further, we found that there was an association between full head alpha attenuation and the maximum post-operative delirium severity. So that's that delirium outcome itself. Further, when we didn't look at the whole head, because that's not especially practical for a quick clinical test, but only looked at the frontal electrodes, we found that that same relationship held. Finally, from all of this, we developed some basic cognitive neuroscience questions. So these bioelectronic signals, looking at a kind of strict clinical outcome, actually inspired us to ask about this nature of alpha attenuation. And though I won't get too deep into this, this is actually the subject of a pending R01 application with my collaborators, Jeff Brown, Dyke, Simon Davis, Christina Krajcic, Heather Whitson, and Marty Waldorf. And so in this, we're basically asking, is alpha attenuation reflecting in an adequate sensory response to visual input? Because if it is, we fix that by enhancing the perceptual stimulus. However, if that association between diminished alpha attenuation and a tendency toward inattention is actually a product of a deficit in the attentional control systems of the brain, the things that allow us to pay attention to a coming visual stimulus that we know is coming because we just opened our eyes, then that enhancement is different. That's something we'd enhance, say, with training or with TMS. And so to test that, one way you could do it is to look at whether alpha attenuation remains in the dark. This preliminary data from Juan et al. Suggests that it does, at least in younger adults. Whether it does in older adults remains to be seen. And this is just one way we're investigating this. We're also looking at a variety of more sophisticated EEG techniques and imaging techniques. And this is an area I'd be glad to talk more about at the coffee hour. Shifting gears a little bit, I'd like to tell you, though, about our current perioperative research studies. I hope I've convinced you that there's some value in looking at a disease process and how bioelectronic medicine can help us to dig deeper into the risk factors for it, like we saw in delirium. Here, we have 2 delirium-focused research studies, though, that use slightly different aspects at the nexus of engineering and clinical medicine. All of this work, POTENT and HIPPY, these 2 studies are underpinned by a concept known as the brain-heart immune axis. And so we developed this concept. And basically, there's evidence to show that the brain and the heart are connected, the heart and the immune system and the brain. And all of this connectedness comes through the vagus nerve. And although some of my collaborators don't like this, I feel for a non-medical audience that this sort of grounds it. So we've all heard of the sympathetic nervous system, fight or flight, the thing that kicks in when our ancestors were chased by lions. We've also heard of the parasympathetic nervous system, the rest and digest. And the parasympathetic and sympathetic nervous system should be relatively in balance. However, in certain states, they aren't. When we age, we have more sympathetic and less parasympathetic tone. When we're sick, we have more sympathetic and less parasympathetic tone. When we have an injury like surgery, we have more sympathetic and less parasympathetic tone. When we're anxious, whether it's about a test, whether it's about driving in traffic, whether it's about a pending medical diagnosis, again, we have more sympathetic and less parasympathetic tone. The net result of this is diminished vagus nerve function. So in this shifted state where the sympathetic outweighs the parasympathetic, in a very simplified view, cognition decreases. This is why studies have shown that the more anxious you are about taking a math test, the slower you perform and the less accurately you do. This is why heart rate variability goes down when we're sick and we're tired. It's why in states of high stress, we're more likely to get sick and inflammation is more likely to persist. In the setting of surgery, this is really important because we know there's an injury coming. We know that there's already going to be diminished parasympathetic versus sympathetic tone in our older patients. We know that decreased cognition can occur in delirium, and that persistent inflammation could worsen delirium by allowing for more neuroinflammation. One of the key measures of vagus nerve tone that I mentioned here, though, is heart rate variability. And so the clinical gold standard of heart rate variability is to sit someone who's been resting, who's not had any caffeine or sugar or coffee, alcohol, especially not nicotine, in a quiet chair for 15 minutes and get a 12-lead EKG. Then that data is manually checked and processed by a highly skilled and trained expert. And every little artifact is manually changed by that individual. This is an example of one type of heart rate variability measured in the temporal tone. And I'm happy to discuss other types at the coffee hour, but I thought this was the easiest to understand. So as an anesthesiologist who's literally watched hundreds of people's heartbeat on an EKG for hours on end, I can tell you, nearly all of us have strange beats. We have premature ventricular contractions. We have premature atrial contractions. It doesn't matter if you're 5 or you're 95. It just kind of happens. However, in this graph, you see every beat is perfectly regular. And in this measure, the standard deviation of normal RR intervals, so not any of those weird beats that we all have every once in a while, but those perfectly normal regular beats, we look at the standard deviation of the time between sequential beats of the heart. And if you're younger and you're healthier, this standard deviation should be higher than if you're older or you're sick or your brain-heart immune axis is out of whack. There are other measurements beyond these temporal domains. There are certainly frequency-based measures, there are entropy-based measures, and rather than this 15 minutes in the lab, there are longitudinal home-based measurements taken for 24 hours, and these have really become practical because of wearable devices. And so here you can see some of our data out of our photoplasmography validations with EKG. So in the top panel, you have the electrocardiogram, it's ECG in English, it's EKG in German. You have time on the x-axis in all of these graphs. You see that regular heartbeat here with every QRS interval. You see the plasmography going up and down after some low-pass filtering just to get rid of drift. High-pass filtering to get rid of drift. And then when we plot them on top of each other, we see that there is a very good approximation between each of those QRS waves in the EKG and the peak of the plasmography. Further, if we look out over time and we compare the EKG data shown in blue with the wristband data shown in red, denoted as Corsano, over time, the instantaneous RR intervals reported in milliseconds are very close to one another. So a wearable device, it seems, really can, in good conditions, approximate that gold standard EKG well, but importantly, it can do it while we go about the activities of our daily lives and aren't stuck just in the lab. Now that we understand the brain-heart immune axis and this heart rate variability measure, I'd like to tell you about our two studies. So these are sister studies that have the same inclusion criteria. So we are including 65-year and older patients at Duke University Hospital who are having major non-cardiac, non-intracranial surgery. By major surgery, these are surgeries that are lasting several hours, and the patients are expected to stay a couple of days overnight. Patients in the study are not permitted to be taking beta blockers prior to enrollment because beta blockers alter that sympathetic and parasympathetic balance, so it wouldn't be ecologically valid data. We also exclude for tobacco use. In North Carolina, we're unfortunately in tobacco country though, and the stress of surgery can even prompt non-smokers or people who've quit smoking to pick it up a little bit in the weeks before surgery. And so that's why we don't exclude entirely for tobacco use, but we do exclude for more than minimal. Patients in this study all have a normal resting heart rate of 60 to 100 beats per minute when they're awake and at rest. And all of them have a normal heart rhythm. So they don't have something like atrial fibrillation, which is very common among adults. And we expect all of them to stay for a couple of nights afterward. In the POTENT study, so this is our vagal nerve stimulation study. It's an interventional, we'll go back there, sorry, HIPPY, which is heart rate, and then HIPPY is our observational study. In POTENT, the interventional study, we're looking at the feasibility of older adults self-administering this transcutaneous auricular vagus nerve stimulation at home. And patients are offered the option of concurrent EEG in the full study for a session so that we can see what how the brain is responding to this. All of the patients in this study are somewhat nervous about surgery. But let's face it, most people are a little nervous about surgery. That's a normal kind of human reaction. And so we've not really had a lot of difficulty recruiting for this because it's a way to potentially manage anxiety without having to take medications that we know have deleterious side effects for older adults. This study seeks to enroll between 20 and 40 subjects. Right now we're at 7 or 8. HIPPY is an NIH-funded observation study, and it looks at longitudinal preoperative heart rate variability, both through measurements in clinic and also through a wearable wristband. This study was powered for post-operative delirium. So we have enrolled 135 subjects, and we're at about a 30 to 33% delirium rate. So this study is really looking at the observation of heart rate variability and the outcome of delirium. POTENT study protocol goes something like this. Our patients kindly take our calls, they talk with the team, and if they endorse anxiety or they score at a certain level about surgery and anesthesia-specific anxiety, they are offered the ability to enroll in the study. When they come in to see us, which we usually schedule at the same time as another clinic visit, their pre-anesthesia and surgery screening visit, they have an EKG if we don't have a recent one on file. We draw blood, usually just piggybacking that off of our regular pre-op blood draw. And then we teach them to use this device, which is a transcutaneous auricular vagus nerve stimulator. It sits on their ear, and they're allowed to just sit and do any other quiet activity they want, as long as it doesn't involve water. That's the one thing. We don't want people getting wet. And at the same time, patients are given a smartwatch wristband that will monitor heart rate variability until surgery. At home, each day, patients are instructed to wear their smartwatch whenever they're not in the shower or swimming, and to use their vagus nerve stimulator and to check it either on a log or a web form, or even by calling us if that's easiest for them. Then we offer patients the option to come into the lab, where we evaluate how their brain changes, their alpha power, when they use TVNS. The idea is that if patients are feeling more relaxed and less anxious, their alpha power should increase when they use this device. Here I have a picture of what an EEG looks like. And then there's Travis Larson, who's an MD PhD student in my lab, and Sloan Soyster Hines, who's our lab manager. And you can see our kind of procedure here. On the day of surgery, patients come back. We ask them to use their TVNS device in the car when they're driving in, or while they're waiting in the waiting room before their case starts. And then we check on them twice a day after surgery. We draw blood in the morning, usually just with their regular morning labs. We perform a delirium assessment twice a day, and they keep the watch on until day 2 after surgery. Here we have some preliminary data about the Amsterdam perioperative anxiety and information scale. So these are the questions that our patients answered, and this is a scale about kind of how much anxiety they're feeling. We have clinic visits here for both the potent subjects and the hippie subjects. I know that this is being recorded though, and because this is an ongoing study, I'm going to ask that we don't post this part, because I don't want to bias any future participants who might find this on YouTube about what our results are. Sorry. Here we see that for potent subjects, shown in blue, and hippie subjects, shown in yellow, before any kind of stimulus is administered, there's equal preoperative anxiety. However, on the morning of surgery, everybody feels a reduction in anxiety. For the potent patients who used TAVNS, it was about 4 points. So they went from about 20 to about 16. But for the matched hippie patients who did not get offered TAVNS, it was only 1.5 points. So they went down to about 18. We're now bringing patients back to the lab to evaluate their response to the stimulation with EEG. And this is our paradigm here, but basically they open and close their eyes every 20 seconds to keep them from falling asleep. They take a nice break in the middle where they can do whatever quiet activities that they normally would at home in the lab. And then we measure their EEG. And what we found, at least in a preliminary subject, and again, I'd ask you not to put this online because I don't want to bias any patients. The alpha power change with vagus nerve stimulation seems to indicate that there is an increase in alpha power with this device, consistent with a greater level of relaxation and emotional relaxation at the level of the brain. I want to end kind of by acknowledging my team. 2 large clinical studies and the analysis, the grants, all of this takes an army. And so I have an absolutely wonderful team behind me here. You can see them. So we've got Izzy, we've got Kevin, Vincent, Sloan, Ava, Vignesh. Here we have Emily, who was the CRC on Hippie and just an amazing job. We have Tahira, who I of Potent as our clinical research coordinator. I have Stephanie, Hannah, and again, Izzy. You can see Travis here. You can see Lila, who is now the CRC for Potent, and just doing a great job, as well as Ken Roberts and Marty Waldorf. I've been blessed to have some incredible collaborators: Marty, Heather, Nicolo, Jeff Browndyke, Simon, Christina, Kara McDermott, Sarah Pasco, Niles, Xiao Yumi, Boyla, and Leslie in electrical engineering have just been wonderful. Leslie was my mentor when I was an undergraduate, and it's just really great to keep those connections up. Karthik, Jack, Ken, and we've been very fortunate to have a lot of funding from the NIH through my ERO3. We have a Strong Start Award, a Pepper Center award that I'm a Rec Scholar for, and several local and foundation grants. We are always looking for great collaborators, especially as this data is coming in from these studies. We are fortunate to have more data than we can really analyze. And we would be thrilled to collaborate or to talk with others who are in this space, who can kind of share some war stories, tips, tricks, advice. Thank you all so much.